Bismillah Rahman Rahim. Assalamu alaikum. My name is Asma Nahid and I welcome you all in Icon 2022 organized by Indus Hospital and Health Network. Today I'll be talking about the topic on pediatric palliative care. Palliative care is recognized and one of the important care for children who are dealing with life-limiting or life-threatening illnesses. Globally, 90% of children suffer from life-threatening illnesses and who need palliative care. Pakistan is an example of poor resources countries who are where palliative care is uh, at absent level or at initial level of development. In today's topic, we will be covering different interesting topics, including demystifying palliative care, challenges in development of palliative care in lower middle income countries, and then we'll be talking about hope and realism maintaining among parents dealing with life-threatening illnesses. Today's first topic we will be covered. That's very interesting topic. If we talk about pediatric palliative care or simply palliative care, this topic is the palliative care component is considered is very confusion. Very few of us understand about its concept and its actual understanding. It's always confusion between end of life care or it's about life care. So today Dr. Justin Baker will be covering demystifying palliative care. Dr. Justin Baker is the chief of division of quality of life and palliative care. He's attending physician of quality quality of life for all, and he's a medical director at St. Jude Home Care, and he's attending he's on oncologist at St. Jude Hospital and Research Center.
Hello, my name is Justin Baker. I'm the Chief of the Division of Quality of Life and Palliative Care here at St. Jude Children's Research Hospital. I'm also the Director of our Global Palliative Care Program. Today, I have the incredible privilege of sharing with you about demystifying palliative care. And I'm going to demystify it by sharing with you key practices to integrate palliative care into the ongoing care of children with cancer. First, as we think about demystifying palliative care, I want you to remember this term, koala kids. So when you think about palliative care, think about quality of life. And we have koala bears everywhere. In fact, I'm going to lift one up here. This is our stress ball koala bear. He's right here in front of me. I have all these other koalas surrounding me so that we can always remember that palliative care is about quality of life. And when you think about quality of life, I also want you to think about the word palliative. And palliative means to cloak or to cover. And so think about this extra layer of support, like my kids' holiday sweaters here that have the koala bears on them, or like our Halloween costumes over here in the upper corner. And so when we think about palliative care, I want us to think about quality of life. Today, we're going to provide a quick review of palliative care. We're going to talk about palliative care here at St. Jude. And I'm going to then talk to you about demystifying palliative care by talking through key practices that you can integrate today to take better care of these precious children and their families. So a second key concept, the first key concept was palliative care is about quality of life. Well, the WHO definition of palliative care is that palliative care is a holistic approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness. Now, another key concept of palliative care is that palliative care is about suffering. It's about attending to suffering. In fact, I'm an oncologist, and as an oncologist, the enemy is cancer. As a palliative care doctor, the enemy is suffering. Suffering comes in so many different forms, so we have to think about the concept of total suffering, much like Dame Cicely Saunders taught us about the concept of total pain. So we have to think about suffering in the context of disease management, physical symptomatology, psychological, social, spiritual, practical issues, end-of-life issues, and death management, the issues related to loss, grief, and bereavement, and take all of that, and at the center of all of that is our precious patients and families. So the key concept to conceptualize is that palliative care is about attending to suffering. Now, there's some tools for providing high quality palliative care. The first tool I want to tell you about is your ears so that you can listen. To listen is to continually give up all expectations and to give our attention completely and freshly to what is before us, not really knowing what we will hear or what that will mean. In the practice of our days, to listen is to lean in softly with a willingness to be changed by what we hear. Which gets to the second point, which is that a key tool is empathy and compassion. In fact, compassion is one of my favorite words. Compassion means to suffer with. Kom, pati, literally means to suffer with. We must suffer with our patients and families. We must understand what they're going through, and then our heart has to be moved to do something about it. And then the third key concept is we must use a multidisciplinary team. It's not enough just to have doctors working on this or nurses or psychologists. We have to all work on this together. A truly holistic approach takes a team. And we have to realize that a patient and family can be suffering from so many different perspectives that we need a multidisciplinary team to care for them. Two additional key concepts I want to bring up are involving the child. Children really need to be brought into this process. They may have questions and concerns, even though there may not be immediate answers. And we have to help the child not feel alone. We have to engage them more and more in this process. And then another key concept is communication. Communication, we're going to talk about this more later. Communication needs to be culturally appropriate, honest, child and family centered, developmentally appropriate, and timely. And what I mean by that is it needs to be linked to concrete experiences. And so we'll talk more through that concept. Another key concept to demystifying palliative care is that palliative care needs to be integrated. It's not that there is a curative approach and then a palliative approach and then end of life care. No, it is integrated throughout. And you can see in this model here, in this figure, that palliative care starts at the beginning of diagnosis and then works its way through all of the care of this particular patient and their family. So it needs to be integrated throughout the experience. You might ask, does integrating palliative care actually make a difference? Well, we actually have studies in the adult world to show that it makes quite a big difference. In fact, if integrated early, patients with this incurable type of cancer have better quality of life. They experience less anxiety and depression. They use fewer hospital resources. They get less chemotherapy in the last 2 months of life. And amazingly, they even lived longer. That's why the studies in the New England Journal of Medicine. And so this really gave birth to a whole other field, the field of palliative oncology. And in the pediatric world, this is a field that we've really been able to lead in here at St. Jude. And it's this overlay of palliative care and oncology at this cross section. And you need to ask yourself, well, does integrating palliative care make a difference in pediatrics? And I'll tell you, we've done many, many studies here at St. Jude, but none of them have been randomized controlled trials. None of them have been specifically prospective studies looking at this question. But when you take all the evidence together, one of our amazing faculty members here, Dr. Kay, summarized this in a systematic review that has shown that there's an increase of integration of subspecialty pediatric palliative care over time. And when you do integrate pediatric palliative care, there's improvement in patient symptoms, there's improvement in quality of life, and patients are more likely to experience a meaningful event in the last month of life. Additionally, there's increasing documentation of a patient's and family's psychological diagnoses and mental health needs, as well as it's more common that parents would state that their child's dying place had been a good place for their family. Interestingly, when you integrate palliative care earlier, pediatric palliative care, patients receive less intensive care and they undergo fewer intensive procedures. Importantly, this is not associated with decreased duration of survival, and it is associated with improved family satisfaction. And finally, really wonderfully, there's better documentation about these issues. Parents find a subspecialty pediatric palliative care team very helpful. Caregivers endorse improvements in quality of life and decreased caregiver burden. And family members report that healthcare providers are more willing to listen to their concerns and that the healthcare providers talk more with each other. So, absolutely, integrating palliative care makes a difference. So, the specific way we do this at St. Jude is really these 3 tiers. The top tier is easiest to talk about. That's the consult base. So, when you're talking about integrating subspecialty pediatric palliative care, most programs have a consultant-based model where a consult team will come and help if somebody calls and says, please come see my patient. But you really need to integrate at all 3 of these levels. A second level is specific population and level of care. For instance, here at St. Jude, every single patient who's a bone marrow transplant patient has integrated palliative care right from the point of consultation with the bone marrow transplant team. Our team meets with them at the same time that the bone marrow transplant team meets with them. It is not by consult. It is based on this trigger that every bone marrow transplant patient goes through. And then finally, we have to integrate at the level of institution. And at the institutional level, we have to think about education like this, resources like building a team, and policies. And those policies might include things like access to opioids, end-of-life care policies, or even communication policies. So we've created this sort of approach where we embed a quality of life for all team member into the oncology team. And at points of diagnosis, these are issues we discuss. At points of disease evaluation or crisis, at points of relapse and end-of-life care, and even during bereavement, we have standard operating procedures that we work to integrate into the care of these precious patients and their families. And by doing this, we've really demonstrated that all patients here at St. Jude, any patient who dies of cancer, has integrated palliative care or hospice. And the interesting thing is that was definitely not the case before we started with our palliative care team here. And so if you take this approach, you can improve the integration of this incredibly important resource at your hospital. So as we think about demystifying palliative care, I want to bring up 12 key evidence-based practices. And this is going to improve the care and outcomes of our patients and families. And so these are the 12, but I'm going to go through them one by one with you. And I'm very happy to share this talk with you. And so you can take a look at it later because we're going to have to go quite quickly. So integrated practice number 1, the things you say and the things you don't say, they matter. Communication, as I've already described, is critical. In fact, it's the cornerstone of being a good clinician. This includes advocating for the involvement of the child in the process, as I already described, or at the very least, not lying to the child. We have to realize that our words matter and that communication is the procedure of the pediatric palliative care clinician. Oliver Wendell Holmes said, "Speak clearly if you speak at all. Carve every word before you let it fall." Or Eric Cassell, one of the key palliative care leaders, he actually died this year. He wrote, "Similar to scalpels for surgeons, words are the palliative care clinician's greatest tools. Surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words." Or one of our bereaved parents told me, "The way you tell the truth to families makes a huge difference. If you know the person that's coming in there and they're telling the truth, as hard as it is, but you know they care about you and they love your child, it's okay. As hard as it is, it's okay, and it makes all the difference." I feel like Emily Dickinson said this so well about truth. "Tell all the truth, but tell it slant success and circuit lies. Too bright for our infirm delight, the truth's superb surprise. As lightning to the children ease with explanation kind. The truth must dazzle gradually, or every man be blind." Integrated practice number 2. Establish an effective therapeutic alliance and utilize it to help families throughout the difficult illness trajectory. Provide relationship-based care. This is one of my favorite things I'm going to tell you. If you establish a therapeutic alliance, meaning if you provide high-quality information, if you utilize prognostic information and provide it effectively, if you involve parents in decision-making in the ways they wish, and if you serve as a trusted provider, if you're able to do those 4 things, if you're able to connect with a family better, These patients and families have decreased decisional regret and improved psychosocial outcomes. This is incredible because they do better the better that you communicate and the better and more closely they feel connected to you as their clinician. So provide relationship-based care. Think about concepts like trust. And you're always thinking about maintaining trust and building trust because someday you might have to take some of that trust out of the piggy bank and use it and say, oh boy, you know how much I love your child. You know how much I care about your family. I'm worried that maybe we're not making the most loving decisions we possibly could right now. Oof. If you say something like that without having a good amount of trust in a family, it is not going to go well. So make sure to be building that trust with that family because it makes a tremendous difference. Integrated practice number 3, understand the illness experience from the perspective of the child and family before establishing goals and offering treatment. Provide empathic responses. What I mean by this is we have to understand that the impact of illness has a tremendous impact on patients and families, and that values, fears, and hopes influence decision-making. And uncertainty about the future is a great source of distress. So we need to be asking, how has being sick been for you and your child? What are the most difficult things you and your family have had to endure during this time? I think this is a very powerful video that I share with you to get this point across. Make sure to be listening with an open heart. As I mentioned, a key principle is empathy and compassion.
So what is empathy and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So I had a miscarriage. At least you know you didn't get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now. I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
What makes something better is connection. So we have to make sure that we are providing that relationship-based care and understanding that the perspective on illness from their point of view. Integrated practice number 4, establish goals of care in collaboration with the patient and family and provide goal-directed treatment. Without knowing the goals, we're simply doing stuff to the patient. It's a very complex decision-making paradigm. Even after the disease has come back for these patients, it's hard to make these decisions. And we have to realize that there are multiple goals of care that can be involved. And that first goal is cure. And thankfully, many children can be cured of their cancer. Sometimes there can be this secondary goal, which is one of leaving no stone unturned. So perhaps the cancer has come back, or perhaps it is very difficult to fight at the beginning. Well, people want to make sure that we try whatever it takes to verify that perhaps we can move back into a goal of cure. Or going forward, perhaps the goal is to live as long as possible. And people are willing to be admitted to the hospital for high-dose chemotherapy to try to live as long as possible. And sometimes people may move on to a goal of living as long as possible and as well as possible, meaning I want to continue receiving treatment for my cancer, but I want to make sure that I stay out of the hospital, that I get to be with my friends as much as possible. And then finally, it's quite common that people move to a primary goal to live as well as possible and not really provide any cancer-directed treatment, really focusing on the issue of comfort. All of these goals are in the context of evolving life and medical goals. Additionally to this, as we demystify palliative care, I want you to realize that every single one of these goals, not just the last one, has an integrated dual goal of comfort. Families very much want their children to be cured, but they also want them to be comfortable at the same time. So as we think about the goals of care, we also have to help families realize where we are. And sometimes families don't realize that cure is unlikely or impossible. So we have to help cultivate prognostic awareness. We have to help them think about the fact that their child might get sicker and that might come soon. But first, just as Brene Brown explained, we have to jump in the hole. We have to understand the illness experience from their perspective. And then we have to recognize that these decision-making factors may well come into play. Help a patient and family experience suffering or quality of life. What is a good day to that particular patient? How about the actual prognosis versus the understanding of the prognosis? What about a child's wishes? How about their hopes and their values of this child and their family? Relationships play a major role, not just the relationship with the medical team as I've described, but relationships with other family members and friends. And then how do these parents define being a good parent to their ill child? All of these issues lead to the goals, and these goals then lead to treatment options and decisions. And we have to make sure that we're not simply doing because we can without fully contemplating if we should. Again, that doesn't mean that we should not be providing cancer-directed treatment. It means we need to be thoughtful about where are we in our goals of care. And then quite frequently what we do, especially at the end of life, is we provide an option to a family and then we try to talk them out of it. And then when they choose that option, we get mad at them. And what I want to tell you is that a choice is only a choice if it's indeed a choice. And what I mean by that is, if we feel like it's only a bad option, we don't need to provide it. We don't need to talk about it. We should take some of that decision-making pressure and put it on ourselves and help families navigate that. Integrated practice number 5, as we work to demystify palliative care, is we have to understand the importance of hope, even in seemingly hopeless situations. Proper hope is what gets us through the day. In fact, it is the thing with feathers. One of my precious patients was going through an experimental bone marrow transplant, and she was going to die from her cancer, and she was told that by her oncologist. And I went into her room and I saw this quotation, and this quotation, I said, "Oh, can you tell me what you have written? Why have you drawn this on your window?" And she said, "Oh, Dr. Baker, I just love this quote. She stood in the storm, and when the wind did not blow her way, she adjusted her sails. Hope anchors the soul." I said, "Oh, that's so powerful." I was worried. I didn't think she understood. So I said, "Tell me more about why you wrote that there." And she said, "Oh, Dr. Baker, I just want to make sure everybody knows that even though I'm going to die from my leukemia, that I remain hopeful. And what I'm hopeful for is that other children won't have to die from theirs because of the experimental trial that I'm enrolled in." Oof. I looked back at her and a tear began to come down my eye, and I said, "That is so amazing. Is it okay if I take a picture of your window and tell people about hope? because I've never heard anybody explain it so beautifully as you just did to me. So what we have to realize is that no matter what goal of care we're in, hope is sustaining that goal. And that by sharing about hope, by sharing about prognostic information, we are not stealing hope. We are not negatively impacting hope. And it used to be that we would think that parents of children were either in denial or acceptance, or false hope or realism. But we've come to really realize that that's not the case. In fact, parents have told us, even as their child is very close to dying, they said, partner with us and realize that even though we are believing that our child will be cured, we're recognizing that our child is dying. Or watch this quotation here. Partner with us and witness the transformative love of hoping for the impossible and the improbable, while accepting the painful reality that our rare and beautiful child is gracefully exiting this world. Partner with us and witness the transformative love of hoping for the impossible and the improbable, while accepting the painful reality that our rare and beautiful child is gracefully exiting this world. So if to ask, what are you hoping for? What else are you hoping for? This is so helpful. Tell me more about what you were hoping for. And we want to use these questions to understand language being used by the patient and family, regardless of where we are in our goals of care. And they will help us tremendously as we think through how to navigate this situation, because hope underlies all of this. It underlies all of these decisions, all of our treatment options and decision-making process. Integrated practice number 6, assess, prevent, and treat pain. Do not be an opiophobe, and help your families realize they should not be either. In fact, I want to challenge you and ask you, do you have these pain-related policies? Do you have a policy about needle and injection site interventions? Do you have a policy about the assessment of pain with vital signs? Do you use an individualized pain goal and the appropriate pain scale? Do you have a policy about emergent access and availability to multiple opioids? How about a policy about assessment of pain within 1 hour after the intervention being provided? Or a policy about opioid dosing guidelines? All of these are critical in your hospital. And I'd encourage you to go check today. And if they're not there, work on it. Contact me. I'm happy to share all of these policies with you, because this is critical. Do not be an opiophobe. We must work to prevent and treat pain. Integrated practice number 7 as we demystify palliative care. Measure symptoms and level of distress and address the symptoms of greatest concern. We have to work to prevent a difficult moment at the time of death, and we're going to talk more about that. Unfortunately, the symptom burden increases as disease progresses. And when you see the symptom burden increasing, part of the reality is we aren't doing a good job assessing symptoms. In fact, when we look at how common people have these symptoms, if we proactively assess them, many of these symptoms are causing distress over half of the time, even as a patient is dying. And what we know is that if you assess symptoms proactively, if you become a good symptom assessor, patient outcomes are improved. In fact, even survival may be improved, as was found in this particular study. Thinking about symptoms, though, we also have to realize that a patient's suffering weighs so heavily on everybody involved. And in these studies that I want to speak to you about, parents in this first study who felt that their child's final day was overdue. In other words, parents who wished that their child had already died, frequently spoke about the pain and suffering that the child was going through. Or the second study, more than 10% of bereaved parents considered hastening their child's death. And this was more likely if the child was in pain. Or this third study, parents of children who died of cancer who felt their child died in pain or had a difficult moment at the time of death. This is actually many studies. They have worse bereavement outcomes. And we're going to talk about that in just a minute. And the reality is, empathy, as we talked about, an open heart, compassion can impact symptoms. One of my patients told me that talking to a compassionate listener made her feel like a new person. So treating symptoms is very much about listening, having an open heart, and being willing to work with your team to try to make an impact for that particular patient and family. Integrated practice number 8, create an opportunity for very ill children to receive care and die in their preferred location of death, even at home. We created a home-based program here that has made a tremendous difference. We're able to provide care in this. This is an inpatient freestanding hospice. But mostly this amazing group of people provide care in the home setting. And we have 5 full-time nurses, 2 social workers, a chaplain, a child life specialist, a program coordinator, and a part-time bereavement coordinator. And this program has made a profound difference in the care of our patients and their families, because we're able to take the clinical care, the care that we provide here at St. Jude Children's Research Hospital, and move it into the home setting. Integrated practice number 9, facilitate legacy development. Help our kiddos and their families think about last wishes. What we really have to understand is, as we've described, what are you hoping for? My first patient I want to describe to you is somebody who had this terrible alveolar rhabdomyosarcoma in the back of her mouth. And she was approaching the end of her life. And she said, Dr. Baker, I just want to make it until my sister is born. And so we decided to put a tracheostomy, not something we would usually have recommended, but in order to help her get to where her sister was born. And we used that home-based care team that I just described to you. And look at this beautiful second picture of her, sitting there holding her remarkable and lovely little sister as she's grown. Or a patient in the middle here who wanted to throw a party. He wanted to throw a party for all of his friends, and he wanted that party, that cake, to be of a minion. And you'd see that's a cake. It was a delicious cake. Or other patients and families have decided that they want to record songs for their precious family members. And one such song was Ed Sheeran's Perfect. And one of our patients sang Perfect for her mother and put that onto a recording. And that mother listens to that very regularly. Integrated practice number 10, prepare the patient and family for the possibility of incurable illness, disease progression, and death. Do everything you can to prevent decisional regret prior to the patient's death and provide anticipatory guidance. Think of yourself as being in the regret prevention business. What can I do to help families not have regret? Well, families may have regret about choosing the last course of chemotherapy. They may have regrets about not talking with their child about death, about not choosing the best location of death, about not getting a chance to appropriately say farewell, or not having access to psychosocial and palliative care services. And unfortunately, if parents do have these regrets, they have higher levels of anxiety and depression, they miss more days of work, they have worse quality of life, and they even have higher mortality rates. So we have to provide appropriate anticipatory guidance, help families make these difficult decisions, and work to prevent regret. Integrated practice number 11, recognize that appropriate grief and bereavement support is a public health necessity, and know what you can do to be supportive. You, as a clinician, are a critical component of your family's grief and bereavement journey. Here at St. Jude, we've created a comprehensive approach, and we've written about this, and I'd encourage you to look into some of these writings. We have resources such as a psychologist who's a grief and bereavement counselor, and she leads our grief and bereavement program. And we do direct counsel with families, parent-to-parent mentoring. We do provide research. We provide staff interventions and staff education. And then we create a proactive bereavement care plan for all of our families. And what these families have told us, these families who say they have this hole in their heart, I often say I have a hole in my heart and I can hear the wind blow through it. Some days I actually hear that wind whistle through my heart. If I don't feel that way, I think there's something wrong. The 4 prevailing concepts these families have told us about is there's a critical importance of strong and ongoing relationships between you as the care provider and their family. They say that high quality communication while the child is still alive is critical. And unfortunately, they speak about the negative experiences and the negative communication that happens as being a negative during their grief and bereavement experience. And they also talk about there being a critical importance of the institution in helping support families in their grief and bereavement journey. So as an institution, you need to be committed to this. And we provide an annual day of remembrance and lots of resources for these bereaved families. Finally, integrated practice number 12, you have to realize that access to specialty palliative care is a right, not a privilege. Partner with us and refer early. We're here to help. Many people say that a family is not ready to meet with palliative care. But the reality is we did a study here at St. Jude. It was actually at 3 sites. And what we found is it's very rare that patients and families would not want to meet with palliative care at the beginning. So it's quite common that it's actually a gatekeeping effect of the clinicians, that we are the ones standing in the way, and that we are commonly the biggest barrier to appropriate integration of palliative care. So we have to do better, and we have to realize that it is a fundamental human right. In fact, the World Health Organization says they acknowledge that palliative care is an ethical responsibility of health systems, and that it's the ethical duty of healthcare professionals to alleviate pain and suffering. And we have to realize that integration of this, and one of the key and critical components of this, is palliative care. I feel so fortunate that I was able to be a part of advocating for palliative care inclusion into the Universal Health Coverage 2030. And that has now been integrated. Palliative care has been integrated into those statements. So as we close today, I just want to encourage you that access to high quality palliative care is a fundamental human right. And that we have to realize that there is a paradox. And if you love until it hurts, so much of what we talked about today is about loving our patients and their families. And if we love until it hurts, there can be no more hurt, only more love. I'm so happy to answer any questions and available for comment. Just send me an email, and I'm happy to share the slides as well. Have a wonderful day.
Thank you so much, Dr. Justin, for amazingly describing the ways of demystifying palliative care and explaining different ways of and component of palliative care to to clear the confusion about palliative care by focusing on integration of palliative care, communication, involving the child in decision making, therapeutic alliances, and dual goal of comfort. uh, Also by talking about the cultivating prognostic awareness and the very important topic of developing hope and talking about and understanding of importance of hope among parents. It was a fantastic talk. Uh, Moving on, we have, as I mentioned, that Pakistan is a resource poor country, and it comes in lower middle income countries, and where palliative care is at initial stage. And by developing palliative care, we faces different challenges. What are those certain challenges? To talk about and to shed light upon those challenges, we have Dr. Shahzadi Resham, we'll be talking about challenges in development of palliative care in lower middle income countries. Dr. Shahzadi Resham is assistant professor at Aga Khan University and currently a globally palliative care fellow at St. Jude Children's Research Hospital. Uh, um, She is a pediatric hematologist and oncologist by training with a special interest in palliative care. She is currently doing a global palliative care fellowship at St. Jude Children's Research Hospital, Memphis, Tennessee. At AKU at Aga Khan University, she was working as pediatric palliative care physician and a member of hospital ethics committee. It is worth mentioning that upon her return, she will be the first trained pediatric palliative care physician in Pakistan with a vision of establishing pediatric palliative care across Pakistan. I would like Dr. Resham take the lead to explain about the challenges in pediatric palliative care.
Assalamu alaikum, everyone. I'm Shahzadi Resham. I am a global pediatric palliative care fellow currently at St. Jude Children's Research Hospital and a pediatric hematologist oncologist by training and working at Aga Khan University Hospital as a consultant. Thank you so much for giving this opportunity to present and talk about one of the important topics regarding pediatrics palliative care. I have nothing to disclose. So I'll be talking about what's pediatric palliative care and further describing about the barriers in the provision of pediatrics palliative care in low middle income countries and in Pakistan. So palliative care is a holistic approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening and life-limiting illnesses through the prevention and relief of their sufferings by means of early identification, assessment, and treatment of pain and other problems like physical, psychosocial, and spiritual. It's very important to know that it's not just the end of life care or hospice care. It is appropriate at any stage of illness. It continues throughout illness and after death to support the family in bereavement. It benefits the most when it is integrated early and can be provided together with disease directed treatment. It requires an interdisciplinary approach, which includes a physician, nurse, social worker, child life support, child psychologist, chaplain, as a team. So, before moving on to the barriers in the provision of palliative medicines, it's very important to know what's the global need of palliative care medicine. Over 50 million are in need of palliative care in the last year of life. 78% of these deaths will occur in low and middle income countries, and only 14% of the patients requiring palliative care have actually received it. 98% of children needing palliative care live in LMIC, and WHO has placed great emphasis on implementing World Health Association resolution in these countries. Children and adolescents comprise of 77% of total global palliative care needs. Among the regions, Africa accounts for more than half of the need for palliative care, which is 40%, followed by Southeast Asia, Eastern Mediterranean, and Western Pacific. Europe and America together account for only 9% of the need, whereas HIV, AIDS, congenital malformation represent 46% of the need for palliative care, followed by extreme prematurity and birth trauma and injuries. So there are few studies that have been done regarding barriers in general in pediatric palliative care from the healthcare provider, physicians, and staff, which includes a limited or lack of access to palliative care specialists or services, limited physician knowledge regarding the role of palliative care, their discomfort in raising the topic of palliative care with families' resistance to the involvement of palliative care, or they're not ready to acknowledge the incurable condition, lack of our home-based services, language barriers, uncertainty regarding patient prognosis, time constraints of peds oncologists during consultation, cost of palliative care consultations and treatment, parent and staff discomfort with possibility of hastening death, withholding nutrition and hydration, or fear of addiction. And most importantly, communication difficulties between staff and families. Pediatric palliative care development follows public health model implemented by WHO, and which emphasizes on few components, which include policy making, policies, education, training, medication availability, and there are several barriers that can come in between in these components, which can limit our provision of palliative care in our country or in LMIC. There could be lack of laws that acknowledge and define palliative care as a part of healthcare system, a lack of national strategy on palliative care implementation, lack of support from the government, and limited political commitment in the provision of these services, lack of clinical guidelines for the delivery of palliative care services. And Pakistan is facing somewhat similar challenges like no healthcare policy in the provision of palliative care, no legislation or regulations or national strategy for palliative care. It's been briefly referenced in our National Cancer Control Plan. Currently, no national palliative care associations or regional care network exists to advocate for service and training, but efforts are being made to get palliative care recognized in the system and into the practices. Healthcare providers have limited or no knowledge or education regarding palliative care, and education is needed at two levels, basically at the basic training level for healthcare professionals, including physicians, nurses, our mental health professionals, volunteers, and therapists, and specialist palliative care training for specifically for people or providers who are working with patients with complex symptoms need, who are teaching palliative care, and who are doing research in palliative care. Curriculum, training, and educational programs in different languages are required and are needed to expand the provision across the globe. There is a need to carry out community education and awareness campaigns through media and public advocacy. And when the services are delivered, the education is needed for patients and families in order to provide how to provide care, including personal care, what to expect symptoms, what symptoms to expect, and how to manage, or along with signs and symptoms of impending death and so forth. In Pakistan, only 5 medical colleges and 3 nursing schools have integrated palliative care education into curriculum till date. There is dearth of training and skilled workforce and limited funding for this specialty. Although CPSP has now recently recognized its fellowship program, but still our regulatory body, which is Pakistan Medical Council, does not mandate palliative care as a part of undergraduate or postgraduate curriculum. There is no official recognition for licensing and certification right now, and only a few advanced subspecialty training programs exist for it. Workforce development issue, education, service delivery, and its access issues across organization are being the most important challenges as far as the healthcare system is concerned. There is a lack of professional training program for healthcare providers, leading to shortage of or inadequately trained palliative care workforce. Limited collaborations and partnerships between healthcare organizations exist, and there is an inadequate access to essential pain medications like opioid supplies and its availability, causing the compromise in the healthcare system, making it as a challenge for the provision of palliative care in LMIC and in Pakistan. In Pakistan, our healthcare infrastructure is not well developed. According to the United Nations number, almost 50% are poor people who need medical support, and they are being forced to access private medical services. Almost 85 to 90% are paying out of the pocket. We lack healthcare insurance. Almost 50% of our healthcare budget is directed towards the curable disease. There is a poor referral system. There are discussions about cost saving versus revenue generation, fee for service model. Medications are required for palliation which are not available. There is lack of industry and pharmaceutical support as far as Pakistan is concerned. Talking about medicine availability, so access to opioid for pain control has been an enormous issue and challenge worldwide. Almost more than 80% of the world's population lacks adequate access to opioid medication for pain control. And only 10% is being consumed by low middle income countries. In 2019, ministerial declaration reinforced the need and commitment to address this disparity in access, in their access and their availability, especially for pain and palliative care. There is variability in consumption per capita around the world. Sia and et al. Has published an estimate of opioid need for 188 countries, and they used average uses in the top 20 countries in the Human Development Index as their reference point for the development of an adequacy of their consumption. And when we talk about Human Development Index, this index is based on 3 indicators like our standard of living, the knowledge, and the healthcare status. And these top 20 countries, of course, they don't include Pakistan in it. And based on considering this as a reference point, the consumption is like 83% of the world countries have low to non-existent access to opioid. 4% have just moderate, 7% have adequate access, which includes Europe and America, and 6% of the countries have insufficient data available. In Pakistan, opioid consumption and its availability is very poor. There are regulatory barriers and restrictions to its availability. We need approval from 4 different ministries and governmental departments to make it available for our patients and population. There are restrictions on dispensing and its procurement, and it's only available for cancer patients. Fixed quota has been given to the federally designated cancer center, and only one valid license is available. Each cancer center requires one specific valid license, which is available only for one center. The specialties that can prescribe these opioids includes oncology, anesthesiologists, and just pain specialists. And as far as the consumption in Pakistan and our region is concerned, so according to the Pain and Public Data Registry, only 0.3 milligrams per capita of morphine is being consumed by Eastern Mediterranean region, which include Pakistan, as compared to the global consumption, which is around more than 6 milligram per capita, and which is probably and possibly due to this unequally distribution of morphine in this region. The pharmacotherapy which is available in Pakistan is buprenorphine, which is an opioid antagonist in the form of sublingual tablets, nalbuphine, which is an injectable form and another opioid antagonist, tramadol, and I would say not the opioid antagonist, but it's a mu receptor antagonist. Work is an opioid, but it is a mu receptor antagonist, whereas morphine is a mu receptor agonist. Tramadol, both oral and injectable form, which is a weak agonist. Tapentadol, which is available in the oral form, is a new addition and has shown some of the effects in our patient, but still there isn't any data in pediatrics, and some adjuvant analgesics. So many, if you talk about the psychological, social, cultural, and financial barriers across the globe, so most of the people have this fear, and they avoid, and the avoidance related to talk about death, and they often have a belief that even acknowledging this may lead them to die or think about dying soon, which is harmful and is harmful. They think it's harmful. Many cultures have expressly prohibited informing patients and families for of their diagnosis and prognosis, but now gradually there is an acceptance regarding sharing of information between the patient and the families. These life-threatening illnesses have a major impact financially as well. And in many countries, the treatment is only available to those who can afford it and who can pay for their care. So in summary, if we talk about that, the palliative care still is a new new addition to the health national system, particularly in low middle income countries. And we know a public health approach is needed to foster the development of these services and to overcome these barriers. And we all know these barriers, and we're so hopeful that these barriers can be overcome, and the existing resources which are available, they can be adapted to the individual countries to fill in these gaps. But the thing which is needed is to do all of this is the will to do so, and to recognize it as a specialty, the need for people to provide an extra layer of support to what are doing, so and to overcome, and which can in turn leads to the unnecessary leads to prevent the unnecessary suffering for the people who are among the most vulnerable. And I think this will come from the policy making, the government level, and public awareness, recognizing its need, and so forth. Thank you so much. You can reach out to me through this email address, and I'm open for all the questions and answer session. Thank you so much.
Thank you so much, Dr. Resham, for highlighting challenges in development of palliative care in lower middle income countries on very detail. Um, as we know that awareness of issues and challenges is the first step to toward the change and toward the progress. Our next topic is that's very interesting topic is about hope and realism among parents who are dealing with life-threatening or chronic illnesses of their children. Uh, how we can maintain a hope and how we can talk about the reality of the situation and how we can understand the hope from the parents' point of view. Uh, Dr. Ashley Keifer is going to explain the topic and explain the components of the um, uh, uh, this important topic in detail. Dr. Ashley Keifer is pediatric palliative medicine physician at Children's Hospital New Orleans, and she is clinical assistant professor of pediatrics at New Orleans Division of Ambulatory Medicines and Palliative Care. And she has completed hospice and palliative medicine fellowship at the University of Tennessee Health Sciences Center in Memphis. She is very passionate about improving pediatric palliative care uh, in the community as well as bereavement, and have multiple published manuscripts on these topics. She is working on, and currently she is working on a national cross-sectional study to better understand how established pediatric palliative program are providing outpatient pediatric palliative care in the clinical settings. So I would like to take the lead, Dr. Ashley Keifer, to talk about her very important and very interesting topic on hope and realism.
Keifer from the Pediatric Palliative Care Team in New Orleans, Louisiana, in the United States. I'd like to start by sharing a little bit about myself before we get started. I was born and raised in New Orleans, Louisiana, and attended Tulane University for my undergraduate and medical education. I then pursued residency and fellowship at the University of Tennessee Health Science Center in Memphis, Tennessee. It is there that I had the privilege of training at both Le Bonheur Children's Research Hospital as well as St. Jude Children's Research Hospital. And after an amazing 4 years there, I returned to my hometown and started my career. Today, I'm excited to share some of the work that I completed during my time at St. Jude Children's Research Hospital. I will be discussing hope and realism at the end of life from the perspective of bereaved parents. Hope. As we know, hope is a powerful thing. It can help families navigate difficult times, impact the decisions that they make, and change throughout the child's medical journey. Hope can also persist at the end of life and at the time of death. You may wonder how hope might persist at the end of life when a child is dying. Can anyone think of examples of this? What might parents and patients or their other family members hope for at the end of life? Please feel free to share in the chat. Some might say comfort or a hope to limit their child's suffering. What are some other hopes? What if parents continue to hope for a cure at the end of their child's life? As a provider, how would this make you feel? Many providers might wonder that this is inappropriate or false hope. They may worry that the family doesn't get it or is in denial. In the setting of serious pediatric illness, tensions often exist between sustaining hope and expressing prognostic understanding. How can we as providers best navigate this? This is what we will address throughout today's presentation. Historically, this analogy of a swinging pendulum has been proposed to reflect the fluctuation between parents' persistent hope for a cure and their awareness of their child's impending death. Or more simply said, the oscillation between hoping for the best and preparing for the worst. However, this analogy has several limitations. First, the pendulum creates opposition. It implies that the two sides are conflicting philosophies. Second, the ball at the end of the pendulum cannot exist in both spaces at the same time. However, parents who face imminent death of their child often describe hope and awareness as coincidental realities. And finally, if the prognostic awareness side of the pendulum represents the true version of reality, a hopeful parent by default is labeled as being in denial or having false hope. This creates a false dichotomy that traps clinicians into erroneous assumptions about parents' goals and wishes, especially at the end of their child's life. These assumptions can result in staff moral distress, needless friction between staff and families, and repetitive and painful disclosures of a grim prognosis to an already aware family. Or, on the opposite hand, providers may limit prognostic information in an effort to preserve hope. Let's talk very briefly about prognostic disclosure and hope. Studies have demonstrated that honest, transparent disclosure of poor prognosis does not diminish hope. In fact, hope remains regardless of the severity of the illness. In a study of 32 parents of children with cancer, almost all, 88% of parents, including those who recognized that the cancer was incurable or terminal, hoped that their child would be cured. Nearly 3/4 of these parents acknowledged that their hopes differed from the expectations of what was most likely to happen. To better understand how this hope and realism can coexist, we turn to our bereaved parents at St. Jude. At St. Jude, there's a family advisory council consisting of parents, adult siblings, and grandparents of children who are currently receiving treatment. The Quality of Life for All, Koala Steering Council is a branch within the Family Advisory Council. It was established to develop, promote, and expand institutional support for families of children who die after serious illness. The council consists of bereaved parents, a grief and bereavement psychologist, pediatric palliative care clinicians, as well as social work, child life, and spiritual care experts. By partnering with pediatric palliative care clinicians, bereaved parents are able to honor their deceased children while also improving care for future children and families dealing with serious illness. After hearing that our bereaved parents had witnessed this tension that can arise when persistent hope is misinterpreted as denial of reality, we felt we had more to learn. In partnership with them, we began to develop a conceptual framework to allow clinicians to better understand this complex thought process. We began by forming HOPE subpanel of the Steering Council. We convened several HOPE Hear Our Parent Experience forums where we discussed these concepts verbally, and later had parents share their experiences and reflections in writing. We asked the following questions. What did hope mean to you during your child's illness, particularly toward the end of your child's life? Did you ever feel hopeful and realistic at the same time? And what did that experience look or feel like to you? 11 parents shared in 2 face-to-face hope forums, and 9 parents shared their written experiences. Bereaved parents identified 7 working definitions of hope in the face of a child's advancing illness and approaching end of life. Several examples are listed here. Hope is a choice, a decision to not give up. It means I can be here, even though here is an unthinkable place. Hope was my vehicle to cope. Bereaved parents distill their experiences into 3 variants of hope. Hope for a cure, hope for life beyond illness or a return to normalcy, and hope for comfort or the mitigation of suffering. Collaborative reflection on the question, what did hope mean to you during your child's illness, particularly toward the end of your child's life, generated 6 unique motifs. Hope as an action to dream and wonder, hope as a survival mechanism, hope as validation of the good parent role, hope as an evolving experience, the persistence of hope for a miracle, and the existence of hope at death and beyond. Consolidation of parent responses to the question, did you ever feel hopeful and realistic at the same time? What did that experience look or feel like to you? Yielded unanimous belief that parents facing the likely death of a child experience both profound hope that their child will survive and coinciding understanding that their child will likely die. I will now take a minute to read several quotes from our bereaved parents. Hope is the antithesis of despair, not the antithesis of reality. The awful, painful, unavoidable reality from the moment of diagnosis and in ever increasing measure was that my beautiful little girl was going to die. In the midst of that sure and certain knowledge resided hope. To be hopeful is a function of the heart and a decision of will. To be realistic is merely a function of understanding the most likely outcome. They are not mutually exclusive, nor are they at odds with one another. They do not need to be in balance. There is not a sliding scale that allows them to coexist by degrees. They are independent of one another, and they are as individual as are we. Two parents, or a parent and a clinician, can share the same view of reality and not share the same hope. Hope and realism were in conflict the whole duration of my child's treatment. Even when the latest scans would bring good news and hope would rise, realism was like the devil on the other shoulder, always saying, yeah, but. When the doctors told my child there were no curative options and it was time to go on hospice, realism had the upper hand by far, but hope was still there. When we were told that my child was terminal, we understood what that meant, and we knew most likely he would die from his illness, barring any other tragic event or a miracle. That being said, I remember telling someone, we are living every day as if it could be my child's last, but also as if he might live forever. That was hope. The knowledge was my child was probably going to die. The hope was he just might be the exception. In the darkest places of worry, sadness, and fear, there was the tiniest bit of light I would call hope. I knew and completely understood what we were facing, but in hope, I was not giving up on my child. When someone plays the lottery for a chance to win, the odds are terrible and are stacked against anyone who buys a ticket. But having a lottery ticket in hand for one day gives a person the chance to dream and wonder. Hope gives you the opportunity to dream and wonder about the possibility of your child beating the odds. While I know these quotes are very long, I think their words and messages are very meaningful and worth sharing today. Crafting a visual was a very meaningful goal of this project as well. We met with a panel of graphic design artists to review the goals of this collaboration. We used the exact language the parents provided to guide our figure development. We participated in 5 brainstorming sessions to create this final image, designed to stir feelings related to balancing hope and reality across a child's illness journey and at the end of life. What do you notice about this figure? How does it relate to hope? How does it relate to bereavement? I'll pause for a minute to allow for interpretation. First, the figure is intentionally amorphous, androgynous, ageless, and not affiliated with a particular race or ethnicity, allowing space for diversity of representation. The windswept circle represents the life cycle. The flowers illustrate the beauty and fragility of life. Notice that the figure is simultaneously watering the flowers while also cradling a flower as its petals drift away. The watering can symbolizes the good parent role and the parent's hope to continue supporting and nurturing the child. At the same time, as the parent pours life into the child, the parent also acknowledges the falling petals and gently allows the child's spirit to let go. Importantly, even as the petals fall from the hand, the flower does not appear any less whole. The image also captures the profound emotions that exist in the space after a child dies. The figure who continues to hold the flower symbolizes the ever-present awareness of a parent who lives with the reality of a child's death every day, while simultaneously continuing to live themselves. The flower also symbolizes the legacy of the child's life, which the family carries with them forever. The flower, although it no longer lives among the other flowers, it remains through the child's lasting legacy. The petals fall both downward and upward, reflecting the power of a child's life to continue influencing those still physically living, while also making an eternal impact. The flowers being watered swoop upward to the flower, epitomizing the tangible connection the living continue to have with the child who died. At first glance, it's difficult to ascertain the direction of the figure's primary focus. Depending on one's perspective, perhaps the figure is facing the flower, perhaps lending attention more toward the watering can, or existing within both pursuits. A closer look at the posture suggests that the figure might be looking forward, facing an unknowable future with resolve and resilience. However, one might also imagine the figure to be looking away, focusing on the fragility and preciousness of life as the petals fall. Importantly, the caregiver is seen watering other flowers, alluding to the daily responsibilities that exist to nurture family, friends, and work, even in the face of deep grief. Finally, the watercolor palette respects how the illness and grief journey may mute some of life's deep, rich colors, yet a quiet beauty and vibrancy remains. At first glance, the fortification of hope in the face of clinical deterioration may seem counterintuitive. Yet, if one thinks of hope as life-affirming as opposed to death-denying, then this new conceptual framework may begin to take shape for you. Hope can create space for coping. And importantly, reliance on hope does not appear to be harmful. In a study of 89 parents, researchers found that remaining hopeful for a cure near the end of life was not related to increased levels of traumatic grief or symptoms of depression. Parents unanimously emphasize the ever-presence of hope as indispensable, not despite or in opposition to their realism, but rather because of their prognostic awareness. This affirms the growing body of literature in which hope has been described as an essential, powerful, deliberate, life-sustaining, dynamic entity and a source of strength absolutely necessary for day-to-day survival. To demonstrate this point further, let's analyze the spinning dancer. Take a look at the dancer. Is she turning clockwise or counterclockwise? Please share in the chat. Here's a quote from a bereaved parent. The only way I could use to explain the way I felt during the time near the end of my child's life is the image of the spinning dancer. Most of the time, it seems so clear to me and easier to see that the dancer is spinning clockwise. Other times, when I look through my peripheral vision or I'm not looking so intently, my perception changes and I can see the other possibility. She is turning counterclockwise. The reality is that there is not enough visual evidence that tells me one way or the other, but my focus tends to determine what I see. I am thinking that from a clinician standpoint, they often want parents to see the reality of which way they see the dancer spinning. Perhaps counterclockwise, i.e. that a child is likely to die. A parent, on the other hand, wants to see the more natural path of clockwise. The child will continue to live, because it's so counter to think otherwise of our children. I knew as a parent that the possibility of my child's death was a reality I had to face, but I coped by viewing the situation through the hopeful, easier viewpoint that things would work out and he would be healed. I always defaulted to my preferred reality, while still acknowledging on some level that at least a few times I had seen the dancer spin counter to my desires, and that possibility did indeed exist. Parents fear a loss of hope. Therefore, they often choose to think positive, cultivate a sense of control, or accept reality, and then restructure their hopes. We call this re-goaling, and it is why prognostic disclosure is so important. If a parent verbalizes hope as a means for coping or survival, this does not necessarily indicate a lack of awareness or denial of prognosis, nor does it mandate reiteration of a poor prognosis. Parents hope for physicians to recognize this and meet them where they are. If possible, this recognition may carry profound capacity for promoting resilience, whereas if the recognition does not occur, it may cause undue harm to families and healthcare staff. So back to our original question, how do we as providers best navigate when a parent continues to hope for cure at the end of life? Our parent co-authors advocate for use of the following recommendations. 1, avoid judging hopes as realistic or false. Nurture and normalize hope as an essential aspect of coping. 2, partner with patients and families who maintain hope as they navigate the difficult anticipatory grief journey. Align with and foster their hopes. For example, when asked, "What are you hoping for?" many parents will state cure or a miracle. We, as empathetic providers, should align with this hope by responding, "I'm also hoping for a miracle. What else are you hoping for?" When sharing concerns, begin by aligning with their hopes. Consider stating, "While we continue to hope for that miracle, I worry that time may be short, despite our best medical efforts." Ideally, a clinician can use empathetic communication skills such as "I worry" or "I wonder" statements to help parents understand prognosis while also leaving space for hope, especially in the setting of any uncertainty. 3, anticipate and acknowledge the tensions inherent to fulfilling a good parent role within this difficult process. Remember that most parents consider maintaining a positive outlook to be more important than fostering a realistic outlook, and that being a good parent is often linked with sustaining hope. And 4, share information about the coexistence of hope and realism to mitigate clinician distress due to fears about fostering denial or false hope. We believe that better understanding and acceptance of this updated framework may help empower clinicians in their support of families and children with serious illness, particularly in the context approaching the end of life. And finally, I just wanted to mention some possible future directions for this work. 1, we wonder, is this conceptual framework generalizable? Can it be applied to different pediatric centers, other subspecialties outside of oncology, various patient populations? Our bereaved parent co-authors represent different parental roles in geographic regions. However, all of our co-authors are white, and we acknowledge that this is an important limitation and advocate strongly for future work to represent the diverse perspectives of bereaved parents from different races, ethnicities, and religious backgrounds. Second, how might this work affect bereavement? Could exposure to this framework improve parental experiences? Could this work mitigate decisional regret and complicated bereavement for parents after the death of their child? And lastly, how might this work affect provider resilience? Could exposure to this conceptual model through didactics influence the assumptions and beliefs of healthcare professionals? Could this work diminish clinician moral distress at the bedside and promote resiliency in the setting of emotionally challenging situations? And last, I'd just like to take a second to thank my mentors and co-authors at St. Jude, as well as our wonderful biomedical graphic design team. And most importantly, last but certainly not least, I'd like to recognize the parents and children who inspired the development of a new model. And thank you so much for your time.
Assalamu alaikum. I think you are mute. I cannot hear you, Asma.
Assalamu alaikum. Sorry. Can you hear me now, Dr. Resham?
Yes.
Yeah, I was just concluding Dr. Ashley's session. She talked about hope, and that was a very fantastic session on defining hope among parents and how hope prevails among parents, and how, as a healthcare professionals, we can help our parents to maintain their hope instead of avoiding and instead of judging their hope mechanism, because that's very important mechanism to go through from the journey. That's a very difficult journey, that's full of grief, that's full of negative emotions. So how we can respond to the hope mechanism, and how beautifully hope reflects parents' love toward their loved ones. So thank you so much, Dr. Ashley. We'll be moving forward toward question answer sessions. Uh, um, Please drop down your question if related to any talk. And I have few questions. I'll be starting with Dr. Resham. Dr. Resham, your topic was on challenges in development of palliative care. Uh, how can we increase trainings and education on a community level and medical level within individual in terms of palliative care? It's basically, creating awareness at community level and within individuals.
Okay. Thank you so much. First of all, good evening, everyone there, I think, and good morning from here. and very good evening to Dr. Shambil Ashraf. There I could see he's our mentor, and thank you so much, Asma, for inviting us for on this so much important session. So, as far as I would say the training and education is concerned, so first of all, the need is to identify. I think that the important thing is to identify its needs and its important as its importance as an special need for our patients and their families. Besides oncology as a specialty or any other specialty in pediatrics, considering it as considering this pediatric palliative care as an additional layer of support for them, and not only for the families but also for the physicians who are taking care of these families. And once we have identified, and how can we identify that? By creating, first of all, awareness. I think media advocacy or something, spreading out the word that the need is dire, like, and the symptoms are not just physical. The symptoms that the families are going through, they have physical, psychosocial, and spiritual care that can be fulfilled through this specialty, and identifying it as a no, it's as a fundamental human right, not a privilege. So I think when we say about training and education, community level would be giving talks on different platform, making awareness, letting people know what is palliative care, how can we integrate these simple terms, uh, and when we are able to tell them that, okay, this is the specialty, this is are the advantages, and we can provide this additional layer of support. And of course, there is primary palliative care, there is specialty palliative care. So the primary palliative care is being done by every physician, whoever taking care of these families and children. So they can always do that, and I think they are doing it. I think everybody is doing their amazing work. They just have to recognize the importance of it, that that how much supportive is this palliative care is for them. And once you have, I think once you have created an awareness, the training will come on its own, and people will, when people start recognizing it, they'll start having an interest of getting trained themselves as a specialist. So that's, I think that would be my.
Yeah, thank you so much. Yeah, that's, I completely agree. Creating awareness through media, through different talks, and once the awareness will be done, so people will recognize the need of palliative care, and eventually they will start asking for the palliative care, as they'll be considering at their right for having this sort of services and this sort of care. Thank you, Dr. Resham. I have next a question for Dr. Ashley. Uh, what are some ways we can instill hope in our patients? Um, can you explain through examples or cases to instill hopes in our patients?
Hi, Esma. Thank you for having me, and thanks for that great question. I think, like we talked about in the talk, the first step is eliciting those hopes and trying. Dr. Baker also kind of talked about building that relationship with your patients, that they feel comfortable sharing their thoughts. And when you ask them, what are you hoping for? And they say a cure or that the chemotherapy works, pushing past that for what else are you hoping for, and trying to see what other small things that might be more attainable right now. For example, some just hoping for getting back to a little bit more of a normal life, and again clarifying, do you mind telling me more about that? What would normal look like for you? And maybe that's just not feeling as nauseous as I do right now. Maybe that's being able to eat some normal foods that they used to eat. Maybe it's seeing their friends. So trying to learn more about how we can make some of those hopes happen right now while we wait for the bigger hopes. And so, like Dr. Baker talked about, building that relationship of trust so that they communicate those things. And we keep asking more and more to learn more and more about what they might be hoping for and what they mean when they say certain things.
Okay, yeah, that's the things, exploring about their understanding, exploring what their thinking and ideation related to hope. So that's how we can, navigate from the process, and we can, that's how we can instill hope among them. Once we will be aware of their thinking pattern, what's going on, and what they're understanding. So again, I have one more question from you, Dr. Ashley. How can palliative care workers draw the line between hope and wishful thinking?
That's a tougher one. I think we align with their hopes often. So when you have a parent share a hope that you worry is not going to happen, I may say something like, while I hope for that too, I'm very worried that time is short, or whatever, whatever we are actually worried about, or whatever we think might happen. And by saying I worry about this, I'm not a higher being. I can't predict the future, but I want to be honest, and I'll tell them that too. I wish we didn't have to talk about this, but I'm so worried, and I want to be honest with you about what I'm worried about. Um,
Hmm.
just really relying on that honest communication and telling them, I wish that it was different. I
Hmm.
wish that
Hmm.
we could that the chemotherapy would work. So using the I worry statements, um, and then I wish aligns with their hopes, but also lets them know what we're thinking and what we're
Hmm.
worried about.
Hmm. Yeah, that's so beautiful that, walking with them, walking with their hopes, and letting them know that, you also hope for them, and mentioning some uh, I worries and statement with them, that can create a line between wishful thinking and maintaining a hope. Um, Thank you so much, Dr. Ashley. I have one more question for Dr. Resham. How we can increase in the third world countries, social issues and concerns tend to trump palliative care, and it is discouraged. How that can be changed? Like, what do you think that, that trump that understanding can be changed regarding a palliative care?
That's an interesting question. I hope if I better understood it's regarding the, it's again about their awareness of palliative care, if we talk about in the social context, right? Um, so
Mm-hmm.
again, of course, we cannot change things culture-wise. We have to integrate these things and bring awareness according to their culture. The basic things will remain the same. In our social context, yes, creating an awareness regarding what is palliative care. First, most important thing is nobody talks about the death of a child in these palliative care. It's about living their moment and making every day better for them to have their good quality of life without thinking about what's going to be the prognosis for these families and kids. As Ashley mentioned beautifully, that naming their emotions, being there with them, and meeting them wherever they are, it's very important. So in our social context, the myth, the most important and myth is about the it's that it's just the end of life care. If you see Dr. Resham or Dr. Keifer, Dr. Shampal Ashraf, Dr. Baker, they're in the ward, that there must be one child or kid dying in that ward. That's why they're here. So as a palliative care physician, we are not death squads. We are like doctors who are providing a supportive layer in terms of symptom management, discussing family with their psychosocial issues, their spiritual issues, and making their everyday better for them. And when the time will come, if the patient has the around the time of the death and all, we will be there in terms of the end of life care and after the death in terms of treatment. So this is the most important thing which we have to we have to make them clear from the fact that this is not the end of life care. I think this is very important and I think it's appropriate at any stage whenever you ask the support from the palliative care physician or the team, but ideally right at the time when you make the diagnosis so that you can have a better rapport with the family, and it will help you, it will help the primary physician, whoever is dealing with those illnesses, in making their care better with the families and providing this layer of support. I think it's about creating awareness and telling them and getting to know how they feel about it, and then
Yeah.
giving them your.
Yeah. Yeah. Exactly. There are lots of myths associated with palliative care, and the toppest one is, it's palliative care is about end of life care. So dealing with those myths and demystifying those myths regarding palliative care would be really helpful to uh, to uh, fi- to like develop a better understanding of a palliative care and to stop that hurdles in order to avail the palliative care services in social context. I have one more question from Dr. Cashley. Dr. Ashley, I'm so sorry, Dr. Ashley. It's like if realism becomes overbearing for a parent, leading to negative outcomes, how we can re-goal the help instilling, hope. If like it's like I think it's a basic fear of a physician as well to talk about reality of the child, talk about the reality of the disease and the reality of the status of the disease, and if it turns into a negative outcome, so what would you suggest to re-goal the whole process, or how to take that process further?
I think you're talking about the communication of the prognosis
Yeah.
and
Hmm.
parents kind
Yeah.
of facing that reality, and if they respond negatively to that, which I bet I would be appropriate and expected. I think the first step would be partnering with them and giving those empathetic support statements. Like, I want you to know, I can't imagine how difficult it is to hear this news. I want you to know that we're still going to be with you every step of the way. And just kind of providing those empathetic statements, naming their emotions, and also letting them know that you're here for them and you're not going to abandon them and you'll be here with them. And I think as you give them time to process that, asking them again what they're hoping for, but by asking in a way, with everything that we're facing, I wonder what feels most important right now. So you're really centering on, with all of this difficult conversation we had today, what feels most important? What do you hope for so and so for the next few days? Sometimes giving that time frame too, like for the next few days or for the next couple weeks, can really hone in on what they're thinking right now after hearing this very difficult news. Does that answer your question?
Yeah. Yeah. Yes. Yeah, you're mentioning about that what matters the most right now and what's important for the child, yeah.
And I think another way too of asking that, while we worry that time is short, I wonder what is most important right now. And so
Hmm.
really trying to delineate what is meaningful. How can we make this time as meaningful as possible for your family as we worry that time is short despite our best medical efforts?
Yeah, using those warning shots during our communication would be to make them prepare for the upcoming news or upcoming scenarios in their life. Dr. Justin have just joined us, and I welcome Dr. Justin. Thank you so much
Hello,
for joining
friends.
you. And so you can see all of the faces have smiled the time you have joined. We are so excited to see you, and we are so excited to have you in our panel discussion. We were just leading our panel discussion. If you are okay, since you have just joined, if you are okay, should I start? Should I like ask you your first question, or I should?
Sure, yes. Yeah, that's
Okay.
perfect.
So thank you so much. So we have our first question. Uh, in your talk, you mentioned about involving the child, communication, and prognostic communication, diagnostic communication. So, what is the most effective way to involve the child in the decision making and treatment planning while practicing palliative care?
So thank you so much for inviting me to be a part of this. And I think this is such a wonderful question to start with. So I think when we look at the variety of cultures, I've had the great privilege of speaking all around the world to many different cultures. And I think the main issue that we need to recognize is we all can involve the child more. We can involve the child more here in the United States. We can involve the child more there in Pakistan. I think the main way I like to answer this question with such a broad audience is we should think about what is the best way to engage the child in the process. It's always good to have the entire family engage the child, meaning it's quite common that that people will feel that the talking about the diagnosis is going to be totally overwhelming for the child. And so it's quite common that people will potentially lie, trying to even do what is best for the child. I'm quite confident that lying to the child is not what is best for that child. And so when I think through this question, I don't like to answer it quite directly, because I like to say, think about ways that you could involve the child more in the process. One of the ways that we would do that, for instance, here at St. Jude, is we would involve people that do art therapy or play therapy to work with the child, and then say something like, oh, draw a picture about what's on your mind. Draw a picture about why you think you're here at St. Jude. And through that art therapy, we would learn so much more. And then I think another piece that is very important to think through is, what about opportunities to help coach the parents? And so I heard Dr. Keifer before I came on talking about, what are you hoping for in these things? Families have never gone through this experience before. They've never had to experience talking to their child about such difficult things. So we as medical providers, as healthcare providers, as psychosocial providers, need to be willing to help the parents in how we think they could have this conversation. And most importantly, I think in that is being willing to actually talk to their child about it, to ask their child questions, and then to see where their child's mind is. But the main thing I want you to take away from this answer is, however you do it today in your institution, just think of how you might involve the child more. How might we get the child more involved in the process?
Okay, and I think the main barriers is parents' distress, that they might let their child to go through a different negative emotions if they will share about the diagnosis to the children, or they will let them know that they are suffering from this illness. So the child might go from depression, or he or she might have negative emotions or negative impression. He or she might lose their hope. So, yeah.
And Asma, I think one of the problems is it's their body, right? And so the child is going through this, so they know something is very wrong for them. And so they may go through similar emotions, a difficult time, but they're going to do it feeling abandoned, alone, or lied to if we don't involve them in the process. And so their body is telling them that something is very wrong. So if somebody's just telling them, oh no, everything is fine, don't worry about it, or no, you just have a cold, or it's just the flu, or it was very interesting. So when I had the good fortune of doing a TED Talk, and here in the United States, this was about 50 years ago that this person told this story. He had leukemia, and he was told by his parents that he had mononucleosis. And so here in the United States, this used to be a cultural norm. It used to be that parents would lie to their children about what was going on because of fear of how their child would handle it. But now we know very clearly that is actually unethical, and it would be inappropriate to lie to a child and tell them that they have mononucleosis when they have leukemia. So so that I say all this because in many cultures, many people tell me, well, we just don't do that with the children. And again, I'm not trying to say you need to sit them down and tell them that they have this diagnosis and that's what it means. And that, no, we just need to bring them into the process more and more. And that could be through, again, play therapists, that could be through coaching of the parents, that could be through a real variety of opportunities. It could be through, for adolescents and young adults, it could be through a fairly straightforward discussion with the doctor. But the main point is, let's think of how we practice medicine today. Let's think about how we can take care of these patients today, and let's try to think, how can we involve them more in the process?
Yeah, and also providing them a safe space to have this sort of conversation.
Exactly. Very well said. Yes, exactly.
Yeah, and one more thing I would expect that the trust relationship between parents and children are also very important. If we're gonna live with the children, they won't be trusting us in future and in their further decision makings.
That's exactly right. And Asma, that you just struck something in my mind. You're exactly right. And so what we have to do is we have to normalize the process of bringing the child in. So the problem also is sometimes we don't think about this until, oh, now things are going badly. Now let's involve them. Well, now it's really difficult because they've not been involved right from the beginning. So we really need to do this and really change our cultural norm around these issues at the institution that we participate or that we're working, and think, how can we, right from the beginning of diagnosis, involve these children more? And let me share with you one quick story. I had a patient who was 12 years old, and this patient had diffuse intrinsic pontine glioma, a terrible brain tumor that he was going to die from. And his parents were adamant, and they basically said, if you talk to him about this, we will fire you. And I said, okay, well, so I met with the parents each day for 4 consecutive days, and they just said, nope, he's not going to be able to handle it. Nope. And so on the 5th day, I walked in, and it's his parents and this young man, and he had cranial nerve deficits. He was having a difficult time talking, and I walked in, and I had a little bit different strategy. I had a nurse with me. And I just looked at my patient and I said, before we get started, I haven't had a chance to talk to you very much. Just tell me why you think you're here. And so I didn't tell him anything. I said, tell me why you think you're here. And this is what he said. He said, Dr. Baker, I'm here because I have a tumor in my brain and you can't operate on it, but this is the best place to get treatment. And his parents, when I first talked to him, you could see it. They were very mad. And then when he said it, it was like all the emotion came out of the room. Like all of a sudden, like, oh, we can breathe. Oh, we don't have to hide this from each other. Oh, we can talk about this. So the kids know. I mean, the kids know something.
Yeah, that's very beautifully explained through your story. And there's lots of examples. We also, deal over here when parents are not willing to share the diagnosis with the child. I have one more question from you, Dr. Justin. Can you please elaborate on decisional regret? I think we lost. Okay, we have. All right. Welcome back, Dr. Justin.
Thank you. I am experiencing some technical difficulties along the way.
That's completely fine.
I am with you, and I am so sorry.
It's completely fine. I understand. Can you please elaborate decisional regret and how to reduce that through therapeutic alliances with any example?
Yes. Wow. Dr. Keifer and I have worked a lot with bereaved parents, and one of the most difficult things to deal with as a bereaved parent is regret, because you can't really go back, obviously, into the scenario and make different decisions. It's after the fact that the child has died. And so when we think through these things, we have to make sure that we provide good anticipatory guidance, because all of these decisions matter so much. And so when you think about it, you have to think through helping families make decisions about, even in this case in oncology, choosing the last course of chemotherapy. We just talked about discussions with their child. We know from at least literature in high income countries in Western Europe and some in the US and in Canada, that if you involve the child, if a parent talks to the child about their illness or about their soon coming death, they never regret it. And if they don't talk to their child, they may have that regret that they never talked to their child.
Mhm.
And so what we have to do, also some families say, you know what, I thought I wanted to be at home. It was overwhelming and my child was very symptomatic and those symptoms haunt me. Those symptoms haunt me. And so what we have to do is we have to be expert at communication. We have to be expert at helping guide these decisions. And we have to walk with the family and learn what they value, what is most important to them. I heard Dr. Keifer, as I was coming in a little bit late, talking about what are you hoping for? That is such a critical way to assess goals and to figure out what is most important for a family. And what I
Mhm.
like to do, I like to think about kind of preventing regret as the bare minimum of what we do. Because I'm hoping we're not only going to prevent regret, I'm hoping that we're going to create incredible experiences and memories that families will hold on to throughout their grief and bereavement period. And so we begin to help families think through trips, that they may want to take with their child with progressive cancer, or events and activities. For instance, we have one little girl, so we also have to help the children, because children have things that they want to accomplish in their life before they die. This little girl, she was just amazing. She wanted to sing a song to all of her friends and to all of her family members, and she chose individual songs for each one and recorded them before she died and then gave them to her family. Her mother says she listens to this song every single day. And so we definitely need to prevent regret. And Asma, you talked about creating this therapeutic alliance, this deep relationship that we have the privilege of honing and working with these families, and using that relationship to help families make decisions that they won't regret. Or if they have, it's very hard to predict regrets about some questions, but we want to get to know families and say things like, given what it is you're hoping for, knowing your family, maybe some of these are the things we should be thinking about. Maybe we should be thinking about how we can really spend time out of the hospital, because that seems
Mhm.
to be something that John really wants to do.
Mhm.
And then, like I said, building legacy is so important. And so our child life specialists, our art therapists, our music therapists are constantly helping us create memories so that there's this lasting legacy of these children as well.
Yeah, yeah, thank you so much. And I completely agree with how legacy building really helpful for creating a long-lasting effect, and also it's a one way of maintaining a hope when child is experiencing or child having a anxiety related to life after death, or family having experiencing anticipatory grief. So legacy
Right.
building will be helpful to have maintain a hope that your he will not be, he should not be physically with us, but this legacy building will help us to stay connected with child.
It also, yeah, and Asma, it also helps even if you just have people do an art project. We had one of our child life specialists was doing an art project and just said, you can choose any letter and draw a picture. And this patient chose to do the letter D and then created a picture about the word death. And there was concern about this child not knowing what was happening, and the family was worried that, oh, we haven't really talked to this child, I'm concerned. Well, my goodness, I mean, here we are now openly having a conversation about this art piece. So it can do
Mhm.
both. It can create legacy and be therapeutic. And so
Yeah.
I think, again, that's another way, coming back to that first question, of how to engage the child.
Yeah, yeah, that's beautiful. We have one more question. Yeah,
I just
yeah,
wanted
sure.
I just wanted to add to that as well. I think another way that we try to mitigate parental decisional regret is with praise, and especially at the end of life. And
Mhm.
examples where I've really tried to, like, the last words I'm saying to the mom are when we are doing home transports, when we're trying to get patients who are dying or who have very short amount of time left, and their parents voice their hope, or the child voices a hope that they spend those final moments at home. And whether it's grandmother who feels differently, or the patient dying very soon after we get home, always making sure that my last words to the family are, you are such an incredible mom. You obviously love your child so much. Look what we were able to do. We were able to get them home, just giving them that praise that hopefully normalizes and reassures them on their decisions that they've made. And then
Yeah, thank
also
you.
in bereavement as well.
Ashley,
Wow,
that's so good. I think we
that's
also
good.
have to help them exactly like you're saying, Ashley, in providing praise. And sometimes if we're not able to accomplish the goal, also reframing and saying, oh, I know that it felt like getting Johnny home was the most important thing, but you see how Johnny, he just didn't feel that way and he thought we all needed, it was better for him if he died here in the hospital, or things like this. Being willing to talk through these things with a family instead of just having them sit with it, I think is really important also. Because sometimes the difficult thing of constantly asking what you're hoping for, what it is you want to accomplish, all of these, sometimes you just can't. And we need to be honest with families if we don't think it's possible. And even if we do think it's possible and we don't, we then have to help them think through, okay, maybe why couldn't we? What might we have done different? And if it's, hopefully there's not very much we could have done different, then we do exactly as Ashley's saying, and we praise and we say, you know what? Wow, we did everything we possibly could. You are the most loving family for Johnny as you possibly could be. And you've made so many loving decisions, and it felt like the right thing at the time to get him home, but obviously we did everything we could to do that, and he died here. So that must have been his idea. Or, some way, just being willing to talk with the family about these things.
Right. And I think reflecting on all the ways over the past days, weeks, months that they've shown how much they love their child, and how much, whether it's making decisions or knowing all the information and paying attention to the beeping or the monitors, or just being at their bedside, pointing out all the examples of how they've been a good parent.
Yeah, that's so beautiful. We have one more question. How important it is to, and that would be the last question, how important it is to connect with the family after the death of the child as the primary physician apart from palliative care physician.
I think both of us can speak to this. I'll start, and then Ashley, maybe you could comment as well. So it's really interesting. So after the death, so I'm going to say something that sounds probably a little different than what people may have told you, but these families definitely feel like we, as the medical team, become a part of their family. And so after the death of their child, they frequently mourn the loss of their child and the loss of their medical family. And so any point of contact, so let me clarify that real quickly. We should not be behaving like family members. We should love our patients, but our patients and families should be loved in a therapeutic way, in a professional way. And our families may well view us as an extension of their family. But our role then really needs to be, in fact, families told us that there's an institutional responsibility, and meaning we at St. Jude, our institution, we as an institution have a responsibility to create a program to support families. And then healthcare providers individually, such as the primary oncologist in our case, as well as the palliative care provider, they need to reach out and touch base with them to continue that connection. And we do that through a variety of ways. There's letters that we provide, there's follow-up phone calls. We actually also have newly bereaved families connect with past bereaved families. We encourage the primary oncologist to write a letter or make a phone call. It's actually built in our policy that they will. And then we also invite families back to our institution every year. And so we created an annual memorial event. And that annual memorial event has been incredibly important. And we've done that over the last 2 years on a virtual platform. So we've created an opportunity to have a community around that. So it's critically important that institutionally there are things that we're doing, but then also individually that there are things that we're doing to reach out to a family, because they do have that sense of loss of people who knew their child best when their child was so ill. Dr. Keifer, do you have other thoughts?
I think you covered it. I think it's hard. It can be hard with limited resources. even at our smaller program, we've been slowly trying to extend our bereavement support. I think one of the easiest ways to keep that connection is by having a card or a piece of paper on the unit, and that way allowing all the bedside nurses that cared for that patient and the physicians to be able to sign it and leave a little message. And even just that tangible piece of personalized messages from people who knew the child and knew the family, sending that a few weeks or a month or two out is at least a way where the family, after they've left the hospital, after their child's died, they know that people are still thinking about them. So even just that one piece could go a long way in extending that relationship beyond the death of the child.
Oh, yes, definitely. So convenient, but yet effective to communicate your regard for the families and to let them know that they are not abandoned. Yeah. So I would like to request Dr. Shamal Ashraf, chair of our panel discussion. He's our leader. Dr. Shamal Ashraf is director of uh, 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 Children Cancer Hospital and then Indus Hospital. I would like to request Dr. Shamal Ashraf to say something and to summarize our session and to pay thank to our speakers. And yeah, over to you, Dr. Shamal. Yes. I think we are facing some internet issues with Dr. Shamal.
I think you can switch off your camera, Dr. Shamil, so that it won't. Yeah. Thanks.
Dr. Sharif, if you could please rejoin on, so I hope the connection would be a little stable. He will be joining us. Until then, I'll be summarizing our session. It was a wonderful session. I was so excited and I was so nervous for this session. It was the first of its kind. Thank you, Dr. Justin. Thank you, Dr. Justin. Thank you, Dr. Ashley. Thank you, Dr. Shahzadi. For joining us and for participating for this session. I would say that I was so excited to have you guys on board and to hear from you and to get to know the knowledge you have and to transfer that knowledge and bits of information to our uh, country, Pakistan. And my team, including myself, we were so excited to listen, Dr. Justin. You are a kind of hero, and we used to see your YouTube, your TED Talks, and my whole team was like, "Oh, you are inviting Dr. Justin? Okay, that's so great. We will be there." So you are like that for us, and yeah, thank you so much. And I hope you guys also had a fun while recording this session, and you also had a different opportunity to present. And I hope that we'll be keep continue our connection for future, and we'll have continue this sort of session for our team at Indus, for our team at Aga Khan, and for our team at Pakistan. We'll be keep organizing this sort of sessions. Yeah, thank you so much.
Asma, it is an incredible privilege to be here with you. And the only thing that I regret is that we're not able to be together in person. And so for the next one, let's make a deal that we'll do it in person together in Pakistan
Surely.
and have a little bit longer time together to learn from each other. But it is such, I just want to congratulate you for putting together such a wonderful group and such a wonderful opportunity. It has been
Thank
a
you.
wonderful experience, and we look forward to
Thank
the
you.
next one.
Thank you. Thank you so much. Thank you so much. I think it's a big achievement to have this session and in a palliative care. At the end, palliative care wins, and that's more like sort of emotional. Or that's sort of achieving for us. That we are growing, we are taking our
Yeah.
steps to move forward. Dr. Resham, do you have something to say for
Yes,
our?
of course. Thank you so much for your incredible energy and enthusiasm and special interest for this special need. And I think I am so fortunate, and we are so fortunate as a team that we have people who think the same way in terms of taking care of the patient and their families. And Justin said that it's an incredible need to meet in person, learning from each other and seeing what's happening in different parts of the world, and learning from from each other. Yeah, and thank you, Ashley, for your incredible talk. I think it's the first time we are meeting, and it was incredible listening to you. Thank you so much for all you do.
And it's such an honor to know and meet y'all. And I'm so amazed by the incredible work that y'all are doing in Pakistan to try and expand palliative care there. That's amazing. And it's an honor just to know and meet y'all today.
Asma, you all are muted. Asma. Oh. You guys are muted.
Okay. So my name is Dr. Amar Hamid, and I'm a pediatric oncologist and working as a pediatric oncologist at Indus Hospital, and co-chair of this organizing committee of this ICON 22. So on behalf of all my team with heart, I would like to special thank my my colleagues, Dr. Justin Becker from USA, Ms. Ashley from USA, Resham from Canada, and Dr. Shamvil, my teacher, all there, for putting time on this time of Pakistan. It is 7 p.m. of Pakistan time. So you all are here. So it is great to see all you are. And we hope and we pray that this palliative journey of palliative care should be go with all of us, and we will able to establish a pediatric palliative care program in Pakistan with the guidance and mentorship from Justin Baker and all other team, Shahzadi, Resham, and all others. So with this, we are very thankful to all of you for being with us in the ICON 2022. So grateful. Have a good night from Pakistan, and goodbye and good morning from USA. So
Yeah.
thank you all. Bye-bye.
Thank you, everyone.
Thank
Bye
you.
all. Thank you.
Thank you.